Welcome to IAPSM West Bengal Chapter Exam Ready Series for UG. I, Dr. Shamima Yasmin, along with my colleague Dr. Poulomi Mukherjee, will discuss the Community Medicine Internal Assessment paper of Medical College, Kolkata. So let's begin.
So let's start with question 1 of paper 1. So it says define epidemiology, classify epidemiological studies, and mention steps of cohort study. So define epidemiology, it contains 2 marks. Let me tell you, there are some definitions in community medicine which we have to learn by heart. You cannot just make up the definition, just like definition of health, definition of epidemiology, definition of primary health care, family planning, maternal mortality. So these things you have to learn by heart. So coming to definition of epidemiology, it is the study of occurrence and distribution of health-related states, events, and processes in specified population, including the study of its determinants. Every answer usually has some keywords. So keywords here are the occurrence, distribution, and determinants. And the line the examiner will wait for is application of this knowledge to control relevant health problems. So even if you're asked this question in your Viva, this line and these keywords are very, very important. Coming to the next part of the question, classify epidemiological studies. It contains 5 marks. So you give the standard classification where you divide the epidemiological studies into an observational study and experimental study. Observational studies are studies which you just observe. The researcher do not intervene. When the researcher is intervening, then it becomes an experimental study or an interventional study. Stop a treatment, or you can add a treatment. You can give something, or you take something from the normal population. So it becomes a interventional study as the researcher is intervening. So these are the main 2 broad classification. It's either observational or interventional. Now we come to the observational part. There the main 2 headings are descriptive study and analytical study. In descriptive study, usually it is done for any hypothesis formulation, where you discuss any events in terms of time, place, person. It's just describing. Whatever it is, you just describe. So that's a descriptive study. The next part of observational study is your analytical study. In analytical study, you are testing a hypothesis. Already a descriptive study has been done. A hypothesis has been formulated. Now you will test the hypothesis by a analytical study. In analytical study, usually you have 2 groups. There are comparison groups. You compare with another group. It can be a cohort study where you are doing a prospective study, case control study where you're doing a retrospective study, or it can be a cross-sectional study where the data is taken only once. It's not follow-up. That's a cross-sectional when the data is taken just once. And the 4th type is ecological study, where the unit of study is not individuals, but a group of population, or it's the population or a group of people, where you are seeing maybe some rate, some data over place, over some place or some time, where the unit of study is not a person. Coming to the second part, that is the experimental or interventional study, where the researcher is intervening. They can be of various types, like the clinical trials, the RCTs, the field trials, and community trials. All of them are very important, and each can come as a short notes. So you better be prepared with these experimental or interventional studies. The third part of the question was steps of cohort study. Here the question was a direct question where you had been asked to give the steps of cohort study, but usually sometimes you get questions where the type of study is not mentioned. You have to formulate the design yourself. So you have to read the question very well. You have to see whether they have been asking for an incidence. If they're asking for incidence, you have to go for a cohort study where some cue will be there in the question, which will help you understand what type of study design they are wanting. It can either be, they'll tell you that it's a rare disease or it's a common disease. So these cues will help you to find which type of study design they are wanting. So in this question, it was a direct question where had you give the steps of cohort study. So it's a simple direct question where you select the study population. You find a group of disease-free individuals who are at risk of developing the disease or the outcome. You will classify them according to the exposures. You will ensure participants are disease-free at the baseline. This is very important. Otherwise, the study will be biased. Now, selecting the population, you have to do sampling. Whenever you're talking about sampling, two things you have to keep in mind. One, the number of people, how you're getting that sample size. And second is how you're selecting those numbers from the population. So these things you have to write about. You have to follow both in cohort study, you have to follow both the groups, both the ones with the exposure and one without the exposure. And at the end, you have to ascertain the outcome after some time period. And at the end, you will do the analysis in terms of your incidence or your risk difference or your related risk and your attributable risk. So that is how you do the analysis, and the ultimate finding will be you have to give a report, or it has to be the report. The results will be shared. So that is the ultimate aim of the study. The fourth part of the question was the biases associated with the study. Bias, as we know, they are the systematic errors that occurs, especially for a cohort study. There can be a selection bias when you're selecting the bias with exposures and without exposures. There can be information bias while you're measuring or recording the exposure. There can be observer or subjective bias. The researcher who is doing the study and differentiating who is exposed and who is not exposed, there can be some bias. The most important bias specific for cohort study is your loss to follow-up or attrition bias, because we are seeing the result after some time. So in that meanwhile period, it might happen that these participants are lost to follow-up. At the last, you can talk about the confounding, where some erroneous factors are associated with both the exposure and the outcome, distorting the true association between them.
Good morning, students. I am Dr. Poulomi Mukherjee, Assistant Professor from Department of Community Medicine, Medical College, Kolkata. I will be discussing paper 1, question number 2. The second question was, a 15-year-old adolescent boy is brought to school health clinic with complaint of easy fatigability. Examination reveals BMI above 95th percentile for age and sex. The boy spends most of the time on screen-based activities and consumes fast food regularly. What is the most likely public health problem in this adolescent? Identify behavioral risk factor in this case. Mention 2 health consequences with this condition. If left untreated, what prevalence strategies can be implemented at school level for these cases? Which level of prevention applicable to this scenario? Mention the name of national program related to it. The numbers are 2 + 2 + 2 + 6 + 2 + 1. Now, for 2 numbers, most likely health problem is obesity. Behavioral risk factor associated with it in this adolescent is physical inactivity and eating habits. 2 health consequences of this condition, if left untreated, are type 2 diabetes and dyslipidemia. Now, there are many health conditions which are associated with obesity. The risk of type 2 diabetes and dyslipidemia is greatly increased. Similarly, risk of gallstone formation is increased. You can also write hypertension, which is moderately increased. These conditions are more common, so you should write about them. So 2 conditions I have already mentioned. Now coming to the fourth part, that is preventive strategies to be implemented at school level. This is a 6-marker question. The first point will be health education about dietary changes, clarifying the concept of healthy diet. So the school should give health education about dietary changes. What is a balanced diet? What is prudent diet? What should the proportion of carbohydrate, protein and fat in the diet? Taking more amount of fibers, more amount of protein and less amount of carbohydrate, refined sugar in the diet is the main concept of health education. Second point will be ensuring participation in regular physical activities like sports, walking to school. Now, level of prevention which we are applying here is secondary prevention. Why? Because obesity is already present here. The condition is already present here and we are trying to prevent the complications resulting from obesity. So the answer will be, it will be a secondary prevention. And name of the national program related to it is National Program for Prevention and Control of Non-Communicable Disease, NPNCD. So this is the end of the second. Biomedical waste. Biomedical waste means any waste which is generated during the diagnosis, treatment, or immunization of human beings or animals, or in research activities pertaining thereto, or in the production of testing of biologicals. You have to write this definition. Now coming to the segregation of biomedical waste in hospital. What is segregation? You have to write first. This is the definition of segregation. The process of sorting of biomedical waste in prescribed color-coded bags, containers for proper treatment and disposal as per the Biomedical Waste Management Rule 1998. Segregation makes easier the prevention of spread of infection, prevents injuries, makes easier to choose among the options of disposal, reduces the load on waste treatment system. Now coming to the category of bags, there are 4 categories: yellow, blue, white, and black. Yellow coded bag, this is human anatomical waste, animal anatomical waste, soil waste, discarded medicine and cytotoxic drug, chemical waste, chemical liquid waste, discarded linen mattress, beddings contaminated with body fluid or blood, microbiology, biotechnology, and other clinical lab waste. On the right hand side, I have mentioned the method of disposal of this waste. You can write them if you can memorize. Second category is the red coded bag, which are non-chlorinated plastic bag container. They contain contaminated waste, which are recyclable. Third category is the white translucent puncture-proof, tamper-proof, leak-proof container. They contain waste shrubs, including metals. And the fourth category is the blue cardboard box with blue markings. They contain glassware, metallic body implants. Now coming to the third part of the question, which is waste audit. What is waste audit? It is a systematic analysis of an organization's waste stream. It involves physically collecting, sorting, weighing, and categorizing trash to identify exactly what materials are being thrown away, where they come from, and how much can be diverted through recycling or composting.
Coming to question 4 of paper 1, which tells us to write about the sign, symptom, diagnosis, and management of scrub typhus. Scrub typhus, as we know, is a zoonosis where the agent is Orientia sutsugamushi. Earlier, it was known as Rickettsia sutsugamushi. The reservoir is trombiculide mite. Suddenly, we have seen that the cases have increased a lot of case of scrub typhus we are getting. The at-risk people are people who go for camping, hiking, or rafting. Sometimes you get in a question, you get these cues which will make you think about scrub typhus as the professional diagnosis. The patient will come with high fever, 104, 100 fever, 105 fever, with chill and rigor, headache, malaise, prostration. These are the common symptoms the patient will come. You can see a maculopapular rash that appears in the 5th day of illness. There can be generalized lymphadenopathy. The typical feature is eschar, which is an ulcer covered with a blackened scab. It occurs at the site of a mite, where the mite has bitten. At the site of bite, you see the eschar. Untreated cases, the fever falls by the 3rd week. Diagnosis is done by Weils-Felix reaction. Doxycycline is the drug of choice. With proper therapy, the mortality is nil. Regarding environmental control, the clearing the vegetation where rats and mites live help in decreasing the epidemic. Application of insecticides do help. As far as personal protection is concerned, impregnating clothes and blankets with benzoyl benzoate, which is a miticide, and application of mite repellents to exposed skin surfaces while traveling in jungles during epidemic phases might help. As far as vaccination is concerned, no vaccine exists at present. Coming to question 5, where you have been asked as what is opportunistic screening? Mention name of 2 disease of public health importance where it is done. What is the criteria of screening test, and write down the difference between screening and diagnostic tests. Opportunistic screening is when a screening is done in apparently healthy individual who has come to a health facility for some other cause. Just like a missed opportunity where a mother has come with a child for immunization and you are talking to the mother about family planning. And if you miss it, that is known as missed opportunity. Here, opportunistic screening is when the patient has come for some other reason, but you can screen certain diseases. For example, like hypertension, diabetes mellitus. Maybe the patient has come for something else, but you just check the BP and you check the blood sugar. So you can screen for hypertension and diabetes. Just like any other screening, it is usually done. So we can have a lead time and we diagnose the patients earlier. Regarding the criteria of screening tests, it is acceptability, like some tests which are very acceptable. Suppose measuring a BP. Usually patients do not say no to it. But when you have to do a pervaginal examination or something like blood test where children are very scared of, so acceptability decreases. So any screening test which can be easily applied, which is easily acceptable, is successful. Repeatability is when you do the test over and over again, the results are same. So those tests becomes more useful. Validity, it should accurately identify the disease and the non-disease individual. It will give us the exact results we want for that particular disease, and it will tell us the result. Sensitivity is about true positive. Usually we want a screening test to be more sensitive and a diagnostic test to be more specific because we want the umbrella to be bigger. The yield is the amount of previously unrecognized disease that we are getting just by the screening program. How early we are diagnosing the disease and the patient is coming to the health facility for treatment, that is our yield. And the simplicity of the test, safety, rapidity, and the cost effectiveness makes the screening test more acceptable. Difference between screening test and diagnostic test, as I already said, screening test should be more sensitive and diagnostic tests should be more specific. Screening tests should be screening tests are usually less accurate and less expensive compared to diagnostic tests, which are more accurate and more expensive. Treatment usually do not start from screening tests. Treatment starts on the basis of diagnostic tests. Screening tests are done on apparently healthy individuals, whereas diagnostic tests are done with people who come with an indication or who are sick. Screening tests are applied to a large group of people, whereas diagnostic tests are done individually to single or some people who come with the indication or the disease.
Now coming to question number 6A, that is disaster management. This is a 5 marks question. You have to write the definition, no short notes on disaster management. Now first you have to write the definition. Any occurrence that cause damage, ecological disruption, loss of human life, deterioration of health and health services on a scale sufficient to warrant an extraordinary response from outside the affected community or area. This is the WHO definition of disaster management. Now, a continuous and integrated process of planning, organization, coordinating and implementing measures which are necessary for. These are the points. This is mainly the objective of disaster management. You can write a few points if you can memorize. Now we will be going to the stage of disaster management. Disaster preparedness, disaster impact, disaster response, disaster recovery, disaster mitigation. These 5 points you must mention in your writing, and if you can write a few 1 or 2 lines about each point. That is, what is disaster preparedness, what is disaster impact, what is disaster response, and so on. Now coming to the question number 6B, that is control of Ebola virus disease. Outbreak of Ebola virus relies on using a range of interventions such as clinical care, surveillance and contact tracing, laboratory services, infection prevention and control in health facility, safe and dignified burials, vaccinations when possible, and social mobilization. So World Health Organization guidelines for controlling Ebola virus disease rely on early detection, patient isolation, strict infection prevention and control, early intensive supportive care like rehydration with oral and intravenous fluid, treatment of specific symptom improves survival. Key strategy includes the use of approved monoclonal antibody. Name of such monoclonal antibodies are Ansovimab TM or Inmazib TM, or ring vaccination like Arvevo during outbreaks. What is ring vaccination? That is vaccinating the contacts of the cases, combined with safe burial practices and community engagement. So for 5 points, you should mention all the points. That is the clinical care, surveillance and contact tracing, laboratory services, infection prevent and control in health facilities, safe and dignified burials, vaccination and social mobilization. Now coming to the explain why questions. That is question number 7A, that is rule of half is applicable to hypertension community. We all know that hypertension is an iceberg disease. About half of the hypertensive subjects in the general population of most developed countries were aware of the condition. Only about half of those aware of the problem were being treated, and only about half of those treated were considered adequately treated. With this, you can draw this diagram. This is a classical diagram of rule of halves. Circle 1 represents the whole community. Circle 2 represents the person who are hypertensive. Circle 3, those who knows they are hypertensive, and so on. Now, coming to the question number 7C, that is natural history of a disease is important for prevention plan. Natural history of the cognition, including development from the latent to declared disease, should be adequately understood so that we can know at what stage the process ceases to be reversible. So if screening is carried out, earlier disease diagnosis and subsequent treatment favorably alters the natural history of the disease in a significant proportion of those who are identified positive. So the first point is screening. Second point is primary prevention. By identifying the risk factors in the pre-pathogenesis phase, which allows planners to design vaccine, lifestyle campaigns, or environmental control to stop the disease before it starts in the late pathogenesis phase. It outlines the long-term complication and disability patterns of the disease. This allows planners to build effective rehabilitation and management programs to improve quality of life. So you can also give example of hypertension or diabetes at the end for this short notes. Now, number question 7E, random sampling is preferred over convenience sampling in epidemiological study. First point will be elimination of selection bias. Random sampling ensures every individual in the target population has a known non-zero chance of being selected. This minimizes selection bias. Convenience sampling relies on easily accessible participants, which introduces systematic errors and alters the data. Second point is population generalizability. Because random samples are statistically representative of the entire population, the findings can be confidently generalized to the whole community. Convenient samples only describe the specific group tested. Third point, accurate disease measurement. Epidemiological metrics like incidence and prevalence rates require an accurate denominator. Random sampling reflects the true demographic distribution of the population, whereas convenient sampling overrepresents specific easily ranged group. Number 4, validity of causal relationship. We know random sampling establishes causal relationships. Randomization, unknown confounding traits evenly across a sample. So convenience sampling introduces hidden unmeasured traits that obliterates these causal links. Number 5, measurable statistical margin of error. Only probability-based random sampling allows researchers to use inferential statistics to calculate the standard error, confidence interval, and p-value. With convenience sampling, the mathematical margin of error is completely unknown, making the data less reliable of public health policy.
Explain why sentinel surveillance is useful for early outbreak detection. Now, you have to define first what is sentinel surveillance. It is the surveillance of selected diseases or health events through carefully chosen reporting sites, which are known as the sentinel sites. They give us a high quality information on the disease trends. They detect unusual events early and guide public health action. Hence, for any outbreak detection, through the sentinel surveillance, we detect unusual increase in cases before the disease becomes widespread. Regular reporting helps to identify the deviation from the unexpected baseline incidence. Sudden increase in cases can indicate the beginning of an outbreak. The most important is they give us high quality and timely data, as sentinel sites are usually equipped with trained staff, good laboratories, and standardized reporting system. So the data we are getting from there are more accurate, they are complete, and they are reported promptly. So these sites are selected because they are representative and they have a good laboratory and provide reliable and continuous data. So they will help us, they will warn us for early outbreak situations. The next part of explain why was why larval source reduction is more sustainable than repeated fogging in mosquito control. Now, fogging in mosquito control, we are usually attacking the adult mosquitoes. So it will be just a section of adult mosquitoes, while for larval source reduction, we are targeting the mosquitoes even before they become adult by eliminating their breeding places. So obviously they will have a longer lasting, they will we can eliminate those mosquitoes for a longer period. Source reduction like drainage, filling stagnant water, proper water storage, water waste management, they minimizes the chemical use, hence more environmental friendly. So they will give less of pollution. So obviously we will choose them over any chemical methods. Another thing is by repeated fogging, the adult mosquitoes are being exposed to these insecticides over and over again. So there is always a risk of resistance. So any day larval source reduction is more sustainable than repeated fogging and mosquito control.
Coming to paper 2, the first question was a 28-year-old lactating mother with children aged 2 years and 3 months respectively visits primary health center seeking advice on contraception. She wants next pregnancy after 3 years. She has no documented medical illness. What type of spacing method is most suitable for her? Which hormonal methods contraindicated during lactation and why? What counseling points are to be discussed with her? Briefly discuss the unmet need of family planning. So the first part, that is the most suitable spacing method for her, will be copper T and DMPA. Estrogen containing pill or combined OCP is contraindicated for her. Why? Because it adversely affects the quantity and constituents of breast milk and less frequently cause premature cessation of lactation. Now, while counseling, the following points you have to write, and under each point, you can explain them, give 1 or 2 lines. At the age of 28 years old, she has already 2 children, so counseling should be done regarding family planning. You can opt the gather approach while counseling for family planning. The cafeteria choice of family planning, explain her about all the available methods of contraception. Explaining the side effect of contraceptives. Suppose she is choosing copper T or DMPA, you will have to explain about the side effect of those contraceptives. Importance of exclusive breastfeeding because she has a 3-month-old child, and advice regarding infant and young child feeding practices, that is the IYCF practices. Now, coming to unmet need of family planning. What is unmet need? A gap between some women's reproductive intention and their contraceptive behavior. Many women who are sexually active prefer to avoid becoming pregnant, but nevertheless, they are not using any method of contraception, including by their partners. These women are considered to have an unmet need. Among the most common reasons for unmet need are inconvenient or unsatisfactory services, lack of information, fear about contraceptive side effects, and opposition from husband or relatives. According to NFHS 5, India's overall unmet need for family planning is 9.4% among currently married women aged 15 to 49, and which breakdowns to 4% of spacing and 5.4% for limiting childbearing. Unmet need for family planning is higher in rural areas than in urban areas. It also varies by women's education and religion. So this will take you 5 marks. So for 5 marks, you have to write all these things.
Question 2 of paper 2, we have a question from occupational disease, where we have a 48-year-old male patient, one working in a stone crushing unit, comes with progressive shortness of breath. So it points towards pneumoconiosis. X-ray shows upper lobe nodular opacities with egg cell calcification. Hence, provisional diagnosis, we can think it to be silicosis. As we know, workers of mining industries like coal, mica, gold, silver, they suffer from this pneumoconiosis. And extra features also points towards it. So the question asks us to mention 2 industries related to this condition. As we already said, they are mining industries, pottery, ceramics, sandblasting. So these are some of the examples we know of. Then the question asks us to discuss the preventive strategies. So for preventive strategies of any pneumoconiosis, we take it as a primary prevention, where the main work is to reduce the exposure by rigorous dust control, wet drilling, use of PPE kits, adequate ventilation, job rotation, substitute silica with less harmful alternatives, automation, reduction of human exposure. These can be some of the primary preventive methods. Monitoring should be done regularly to keep the silica below permissible limits. Baseline X-rays should be done to find out whether it is developing or not, and regular health education is to be given to the workers. Into secondary prevention, we'll be talking about the periodic medical examination. Once we know the patient is suffering from it, regular X-rays has to be done, pulmonary function test has to be done, treatment should be done. And as we know, silicosis goes with tuberculosis, so screening of tuberculosis will be done. If there are early signs and symptoms, we would give health education and we would go for a job substitution so that the person is removed for a different place the person can work, so that lesser exposure of silicosis occurs. For disability limitation and rehabilitation as a tertiary prevention, we can talk of chest physiotherapies, bronchodilators, safer alternative occupations, and social security schemes like ESI. The question asks us to name some complications which are progressive massive fibrosis. We also know silicotuberculosis is very common, respiratory failure, and pneumothorax. We had to name a program related to these. We have the National Program on Elimination of Silicosis in India, which goes with ILO and WHO. So we can name this program specific for silicosis. Next, we come to question number 3, one of the favorite questions of most examiners, that is severe acute malnutrition. Severe SAM children. Here, we have been asked to describe the causes and clinical features. In community medicine, when you ask to name the causes, we don't only give the medical causes. We also talk about the social causes. So primary causes will definitely be insufficient intake, both in quantity and variety. A very common thing is using diluted milk. But those who are not breastfeeding, those who are using tinned bottled milk, they usually dilute it, as cost of milk is very high. Powdered milk is quite high. So those who are not breastfeeding, so they can use some diluted milk, or the adequate nutrition is not being given. They can lead to SAM children. Poor infant feeding, where complementary feeding is not started at 6 months, that can lead to it. Poor sanitation and infection, leading to many various diseases. Like we all know that malnutrition and infection, they follow a vicious cycle. So infection leads to malnutrition, and malnutrition leads to infection. So there goes a vicious cycle between the two, and the child suffers. As far as the social causes are there, poverty is a very important cause for SAM children, as we see it mostly in the lower socioeconomic strata. Lack of parental education, when one doesn't know what food to be given, with what calorie food is needed, and poor access to healthcare. These are some of the methods which can be social causes of SAM children. As far as diagnosis is concerned, that any one of the 3 following: low weight for height. You have to remember this, it is weight for height. Many students make this confusion, and they always talk about weight for age. But we have to remember, for SAM children, it is weight for height less than 3 standard deviation, the MUA of the mid upper arm circumference less than 11.5, and nutritional bilateral pitting edema. This leads to diagnosis of SAM children. As far as management is concerned, first we have to do the diagnosis, where it can be done by active screening by health workers, ASHAs, going house to house, staff of NRCs who go house to house and screen children between 6 to 59 months using a MOA card and check for edema. It is usually done once in a 15 days or whatever. According to routine, active screening is done. Passive screening for any other institution, like any OPD, IPD, any health facilities, if it is found by passive screening that the child is suffering from SAM, so they are referred. First, it is seen whether they are complicated SAM or non-complicated SAM. We see it is complicated when there is poor appetite. Appetite test is usually done after this diagnosis. That if there is a visible wasting, bilateral pitting edema, severe palmar pallor, sick newborn less than 6 months, there is lethargy in the child, drowsiness, unconsciousness, any complication, we have to be very cautious, because mortality rate is quite high, and we need to refer them to facility or hospital-based cares. As far as management is concerned, we divide it into 5 phases. The first phase is the stabilization phase. This is the first initial phase where the risk of mortality persists due to hypoglycemia. But the patient is admitted in the nutritional rehabilitation center, and food is given at regular interval. F75 is given as per the weight, as per the symptoms, likely regular 2 hours, 4 hours interval. The food is given throughout the night, most common in the morning, because the child can even die out of hypoglycemia. So one has to be very, very vigilant in this stage. Regular feeding is absolutely necessary. They are maintained in a chart. This next phase is the transition phase, where the child is a little more active. the appetite has returned, the edema has gone, the medical problems have gone, NG tube is not required, the child is feeding his own. So we shift from F75 to F100, that is the catch-up diet, and we can give food every 4 hourly. The third phase is the rehabilitation phase, when the baby's weight gain, baby is gaining weight. Now we need to stimulate emotionally and physical developments. These are all part of the activities of the NRC, where the child is also stimulated emotionally so that the physical development becomes better. In NRCs, we have a toy room where toys are there. Children are motivated and mothers stay with them. So even the mothers are taught how to stimulate the child, how to feed the child, what food is needed, which food has more calories, the exact food, when they will go home, how the child should be given food. All these are taught to the mothers. And the major medical problems are solved in this position, and usually the child finishes the 90% of the food given and the child is in a much better state. So we will plan for discharge. When the catch-up weight is more than 15%, or there is 5 kg per day day increase in weight for 3 consecutive days, there is no edema, no medical conditions, are all improved, we can think of discharge. Before that, we will give them the micronutrients needed, the immunization needed, all are given. The mother is taught how to feed the child when they go home, what care, minimum care required. All these health educations are given to the mother. A follow-up is regularly done by the ASHA ICDs by home visits, and also they have to come back to NRC till good recovery. The referral dates are given.
Infant mortality rate. And question number 4, define infant mortality rate. Write down the causes of infant mortality, discuss role of under 5 cleaning. Now, what is infant mortality? Infant mortality is defined as the ratio of infant deaths registered in a given year to the total number of live births registered in the same year, usually expressed as a rate per 1,000 live births. You have to write the formula of infant mortality rate. Now, the causes of infant mortality are following in India: low birth weight, respiratory infection, diarrheal disease, congenital malformation and cord infection, birth injury, and unclassified. Neonatal death makes a major contribution to infant mortality, whereas in developing country, the high infant mortality is mainly due to low birth weight and the combined effects of infection and malnutrition. In developed country, it is mainly due to congenital anomalies, anoxia and hypoxia. Now, what is the role of under 5 clinic? What is an under 5 clinic? It is a specialized community health center that provides comprehensive integrated healthcare to children under 5 years old. Its primary role is to reduce childhood morbidity and mortality by offering a mix of preventive, promotive, curative, and educational service. So what are the main 5 functions? For 5 marks, you have to write the 5 functions. They are growth monitoring and promotion, preventive care, including immunization according to the National Immunization Schedule, curative care for common infections and illness, health and nutritional education, and family planning services. So these 5 points you can elaborate under each point. Coming to question number 5, effective communication is cornerstone of adolescent mental health care. It reduces isolation, builds essential trust, ensures early detection of psychological distress, and facilitates access to professional help. This is the importance of effective communication to address adolescent mental health issues. Now, the second part was explain the role of school and families for promoting positive mental health in adolescent. Now, first, the importance of effective communication. You have to write 6 points, that is, builds trust and emotional safety, enables early identification of distress, reduces stigma and isolation, promotes healthy coping mechanism, facilitates access to professional help, empowers and validates the adolescent. So under each point, you can elaborate them by 1 or 2 lines. I have mentioned the 6 main points, which you should also mention. Now, coming to the role of school and families. The family should provide emotional security and support. Second, it should facilitate open communication. School should foster a positive learning and social environment. And secondly, it should take part in early identification and intervention about childhood psychiatric and physical illnesses. So these 4 marks question. So for 4 marks, family 2 points you should mention, and for school you should mention 2 points. Now coming to the short notes, that is international health regulation. The international health regulation is an instrument of international law designed to prevent, protect against, control and provide public health response to the international spread of disease. It is legally binding on 196 countries, which includes all 194 WHO member states. Member states are required to build and maintain national public health capacity, which include responsible authorities, core capacities, event notification about notifiable disease, verification of information regarding public health risk and query by the WHO. So these are the activities of the member states. Second is the role and obligation of the WHO, that is the global surveillance response coordination. The third is the international traffic and human rights safeguards. International traffic regulating health documents for international travelers, baggage, cargo and conveyance on international voyages. Human rights safeguard, confidentiality and protection of personal data. The requirement of informed consent for medical examinations prophylaxis, ensuring non-discrimination in the application of health measures. So for 5 points, 5 marks, you have to write this much for international health regulation. Now coming to the explain whys. The first question was community-based mental health care preferred over institutional care for long-term management of mental illnesses. 5 marks, you have to write these points. Community-based mental health care is globally preferred over long-term institutional care because it shifts the focus from isolation to recovery and social integration. The 5 key reasons are better recovery and autonomy, social inclusion and support, protection of human rights, reduction of social stigma, cost effectiveness and prevention. Under each point, I have given 1 or 2 lines. You can also mention these lines if you can memorize. Question number 7b. Polypharmacy is a major concern for geriatrics. Now, what is polypharmacy? Polypharmacy is the use of 5 or more medication is a major concern for geriatrics because of the following reason. First is pharmacokinetics. Older adults experience reduced liver and kidney function. Drugs are metabolized and clearer much slower, leading to drug accumulation and higher toxicity levels in the blood. Second is adverse drug reaction. Taking multiple medications significantly raises the statistical probability of adverse drug reaction. This case manifests as confusion, dizziness, and sudden loss of appetite. Drug-drug interaction may be there when multiple drugs are taken, they can interact in the body. Fourth point is prescribing cascade. This occurs when there is a side effect of the drug and the geriatric person takes another drug and this gives rise to another side effect. So this is a cascade effect. Fifth is the medication non-compliance. Complex medication regimens taking many pills at different times of the day are difficult to manage, especially for patients with memory issues or visual impairment. This leads to missed doses or incorrect doses, compromising treatment. Coming to the last question, that is question number 7e, that is total fertility rate are considered a better indicator of fertility than food birth rate. Now, total fertility rate is a far better indicator of fertility than food birth rate because it eliminates the age and gender distortion. Birth rate, we know, divides total birth by total population, including male, children, and elderly. TFR, on the other hand, focuses solely on the reproductive span of women, usually 15 to 49 years of age, removing distortion caused by varying age distribution. Second, accounts for actual at-risk population. Because food birth rate counts for the entire population, a region with a high proportion of elderly people will show misleading low birth weight. TFR provides a highly targeted realistic measure by looking strictly at women capable of childbearing. It indicates the completed family size. Very important because we know that TFR measures the average number of live births a hypothetical women would have by the end of her childbearing age. Fourth, predicts future population growth. A TFR of about 2.1 in many countries is needed for a generation to replace itself. Fifth, better for international comparison. We can compare between different regions, countries, or time periods by TFR. So that is why TFR is a better indicator of fertility than food birth rate. Thank you.
Coming to short notes, the first short note is 3-tier healthcare system. It's a very, very common question often asked in Viva, and also it's a heart of community medicine where how service delivery is given in the three-tier system in a rural India. There are three tiers: the primary care, secondary care, and the tertiary care. The primary care is the first level of contact of the individual with the health system, where the healthcare is provided, where major preventive health services are delivered here. In the primary health centers, the primary health center is the first contact with the doctors. Under it, we have the sub-center and Anganwadi, where there is no doctor, but healthcare workers are taking care of the listed deliveries are being given by the healthcare worker or sub-centers and Anganwadi. These are provided by they are the grassroots level workers. Primary healthcare staffs, along with community volunteers, trained by Anganwadi workers, all they cater to this primary care. The second level is a health facilities who can deal with the more complex problems. They are the taluk hospitals, district hospitals, subdivisional general hospitals, and the first referral units. The first referral unit we know is a place where there is a provision for blood transfusion. We have an anesthetist, we have a gynecologist, we have minimum surgery facilities are available. For the tertiary care, they are the super specialist hospitals, usually the teaching centers, the medical colleges, and they are the tertiary level where complicated surgeries can be done. Coming to question 7, which is an explain why type of question, where it has been asked why population genetic is important for planning community level screening programs. We know some diseases are distributed by genes. There are inherited diseases. So for them, to make more screening more cost effective, we can do some population genetic study and screen those who have the risk of getting the diseases. So population genetics is the study of distribution of genes and genetical variation in a population. So this will help to identify population at high risk for inherited disorders, and their planning screening for these population will be highly effective. This can occur in thalassemia carrier patients. Sickle cell anemia screening is done for some tribal population. Newborn screening for congenital hypothyroidism. G6PD deficiency is more common in male gender. So if we know the disease has some genetic inheritance, we can go for some specific screening for some specific population. The next question is cost-effective analysis plays a greater role in public health than individual clinical care. Cost-effective analysis refers to an evaluation where the outcome are one-dimensional. The cost, that input cost, is expressed in monetary funds, but the results are non-monetary. We're not taking in terms of money. It will be like years of life gained, hospital days prevented, cost per Delhi or quali. That way, disability adjusted life, the quality of life years. So these will be expressed, the output would be expressed not in terms of money, but as per the indicator we are wanting to improve for that program. So whatever input, whatever cost we are giving, the output is measured in terms of these goodness, like the years lived, quality of life. So these are my output indicators. Cost-effective analysis is very important because our country or most countries have limited resources. So we choose intervention that will produce a greater health benefit. Public health is a population approach, and resolves are allotted to maximize the benefit to larger people. So we will only go for a program where spending a little will have a major effect on the population. So which can be measured. Measurable outputs will help us to monitor our program. We can prioritize. We will know where to spend the money more. Priority population approach will be better with cost-effective analysis. Like, for example, immunization. Here, the cost incurred, the input cost, when cost of the vaccines will be much less when we will consider the amount of years the children are gaining, or amount of years they are spending without disability. So this will have a greater effect, and we will know that we have to run these programs with a greater cost-effective analysis. So thank you all. This was some discussion of some of the questions of the paper. All the best for your coming exam. Thank you so much. We discussed the paper of Medical College Kolkata and Community Medicine. So all the best for your exams.